Today, we are going to talk about patients presenting to the emergency department with acute onset dizziness and posterior circulation strokes. We will go through an introduction about and why we are discussing this topic, go a little bit back to basics, talk about some anatomy and physiology that we may have forgotten, talk about key aspects of history and physical exam that you want to be sure to include. We'll go through an approach to the differential diagnosis, specifically using timing and triggers approach, or the ATTEST algorithm. I'm going to let you know a little bit about the workup that might happen for patients if they stay in observation or inpatient, if they present with dizziness or concern for posterior stroke. And I'm going to introduce the acute onset dizziness clinical pathway. As we go through today's lecture, I want you to think of two case examples. The first is a 65-year-old male with a past medical history of hypertension, hyperlipidemia, diabetes, stroke with residual left-sided weakness, complaining of 2 days of dizziness and lightheadedness. He says he's been so nauseous, he really hasn't been able to eat or drink much or take his medications. I want you to think of 4 questions. What will you ask this patient? What are you going to look for specifically on physical exam? What workup will you do? And what will the disposition be? The second case is a 42-year-old male with a history of hypertension that's presenting with dizziness that started when he woke up in the morning after he rolled over. Right now in the emergency department, he's resting in the stretcher and asymptomatic, but he does say his symptoms return when he turns his head. And I want you to think of those same 4 questions. So why do we need to learn about the acutely dizzy patient? Well, 3 to 4% of the patients that you're going to see in the emergency department have a complaint related to dizziness. They might describe it as dizziness or vertigo or lightheadedness, or simply say that they feel imbalanced. About 4.4 million emergency department visits every year are for dizziness, and the cost is about $10 billion. Half of these patients are going to have some sort of underlying medical condition causing their complaint, but 3 to 5% will have a stroke. So today I'm going to introduce to you our acute onset dizziness clinical pathway that will start from the moment the patient is being triaged and will end in their disposition. So let's take it back to basics. While you don't need to understand the complex anatomy of the entire system, it is good to know what pieces play a part. So the vestibular apparatus is located within the inner ear, and it is connected to the brainstem via the vestibular nerve. From there is connections to the thalamus, the cerebellum, the spinal cord, and multiple other areas of the brain. And an insult anywhere in this pathway can cause someone to feel off balance or dizzy. So this is a picture of the vestibular system. It's good to just remember that there are a couple components that might cause a patient to have symptoms. The semicircular canals sense rotational motion, and the utricle and saccule sense linear motion. The electrical impulses are sent to the brainstem via the vestibular nerve from here. So let's switch gears and just talk about strokes in general. You can have hemorrhagic strokes, which are your brain bleeds, or ischemic, which is going to make up a large portion of the strokes that you see. Ischemic strokes can be from in situ thrombosis or embolization from a distal source. The most common place that you might have embolization of a blood clot would be from the heart. So these are patients we think of that have atrial fibrillation, that might have an atrial clot. Maybe they have a large MI and ended up with a ventricular clot. Also, patients with certain valvular diseases might be more likely to develop thrombi there. The other sources that we think of or that patients can have embolization from are arteries. And specifically with strokes, we think of the carotid arteries. The most common embolization source is going to be your internal carotid artery because it directly communicates to the middle cerebral artery. So let's take a look at this picture to the right. The red arteries depict the anterior circulation. This is where the areas of the brain that are most likely affected when patients present with obvious stroke complaints, like weakness of their left arm and left leg, or numbness along a certain area. The posterior circulation stroke is the yellow area, and this is what we're going to be talking about today. So as you can see in this picture here, the posterior circulation affects many areas of the brain. It includes the brainstem, the cerebellum, the occipital lobes, and the thalamus. as well as a few areas of the cortex in certain patients, depending on their anatomy. 20% of all ischemic strokes are in the posterior circulation. So it's very important to know how to work up and diagnose these patients. Posterior circulation strokes are 3 times more likely to be misdiagnosed. So hopefully after today's lecture, you'll feel a bit more comfortable. Let's move on to the history and physical exam. You want to be sure to ask the patient if they have any history of a prior stroke or a TIA. 1 in 4 patients that present to the emergency department with a new stroke have a history. You also want to ask about other risk factors: hypertension, hyperlipidemia, diabetes, smoking, and obesity. It may be helpful to think of the 5 Ds of posterior stroke. This is something that might just help you remember exactly what to ask for. So that is dizziness, diplopia, dysarthria, dysphagia, and dystaxia. When the patient comes into triage, the nurse's screening includes the B FAST. So B is balance, E is eyes, F is face, A stands for arm and leg, S is speech, and T is time. Specifically for posterior circulation strokes, the ones that you want to key in on are the balance. Do they have a sudden loss of balance or coordination? And eyes. Did they have a sudden loss of vision, or do they have a sudden onset of double vision? So this is the portion that would most likely correlate with a posterior circulation stroke. All right, so the ATTEST algorithm is one really helpful way for you to approach every patient that comes in with dizziness. A, you want to ask for associated symptoms. T is the timing and triggers. You want to ask about the timing of onset and anything that might trigger the symptoms. You're going to look for specific examination signs, and then you're going to think about testing that you might want to do. So let's go through each portion. So for associated symptoms, you want to find out, are there any other neurologic symptoms? This might be the part that you run through those 5 Ds. You want to also ask, is there any focal weakness or numbness or change in speech, maybe any vision changes or difficulty with memory? And then you want to think, is there any other underlying medical condition that might be causing this dizziness? As we mentioned before, about half the patients presenting with dizziness or lightheadedness have something else going on, whether that be a large pulmonary embolism. Do they have an arrhythmia that may be transient or persistent? Do they have some sort of underlying infection like a UTI, metabolic derangement that's causing their symptoms? Are they hypovolemic? Maybe they have an upper GI bleed that is causing them to have symptomatic anemia. Maybe they're dehydrated. Or maybe they were started on some new medications that might be causing their symptoms. So the timing and triggers is probably the most important part of this algorithm because it's really going to help you suss out the differential diagnosis. So first, is the dizziness still present right now? And then second, has the dizziness been continuous? Has it been constant since it started? If it's coming and going, is there a specific trigger that brings it on, such as movement? So let's go down the algorithm to try to differentiate between the different vestibular syndromes. So the one we care most about today, which has the most serious underlying conditions, would be the acute vestibular syndrome. These are patients that have a sudden onset of persistent dizziness. It's dizziness that comes and it stays. It may get worse when they move or do certain things, but it is always there and it's constant. It may be associated with nausea and vomiting. They might have nystagmus, some gait unsteadiness, and they might have a head motion intolerance. And then moving over to the episodic vestibular syndrome, these are patients that have coming and going symptoms. So is the question you want to ask, is it triggered by something specifically, or is it spontaneous? They say, no, I've been sitting here, and while I'm sitting here, it comes, and then it goes away all of a sudden without any sort of a trigger. Usually the episodic vestibular syndrome lasts minutes to hours. It's not persistent for days at a time. All right, so a little bit more about the acute vestibular syndrome. Again, these are the patients with the acute onset and persistent dizziness. This is the category where you want to convince yourself that they do not have a posterior circulation stroke, or if there's any concerns, then you go down the algorithm to continue for testing. This also includes vestibular neuritis, which is a very common cause of the acute vestibular syndrome. And this is caused by inflammation of the vestibular nerve, which is depicted on the middle picture on the right. It also includes labyrinthitis, which would be inflammation of the entire system there. Multiple sclerosis, in very rare occurrences, can present as acute persistent dizziness, but again, this is quite rare. And then you want to ask about drug or medication toxicity, such as anti-epileptics that might cause this symptom. So moving on to the spontaneous, meaning there is no trigger that they can identify, and episodic coming and going dizziness. These are patients where you want to think about posterior circulation TIAs. You also have vestibular migraines or Meniere's disease. Other differential diagnosis can include intermittent cardiac arrhythmias, pulmonary embolism, or panic attack, which would be a diagnosis of exclusion. Moving on to the triggered and episodic vestibular syndrome is BPPV, which is benign paroxysmal positional vertigo. Also within this category is orthostatic hypotension. So these are patients you might want to consider doing orthostatic vital signs on prior to giving any IV fluids. It also includes CPPV, which is central paroxysmal positional vertigo, and postural tachycardia syndrome. There's also something called the Bow-Hunter syndrome, which is caused by vertebral artery rotation. So when they turn their head, they actually have inclusion of their vertebral artery. And when they straighten it again, it improves. This is a tough diagnosis to make, but something to think about. I've included this screenshot just for future reference, and the slides are also included in the educational website below. Might be something that you want to screenshot or keep with you when you are seeing these patients in the emergency department. It goes through everything we just talked about before. So let's talk about what you might do in your targeted physical exam. This list here is the targeted ED physical exam recommendations to help you better identify the patients that have posterior stroke that are presenting with this dizziness. This is listed out in the acute onset dizziness clinical pathway underneath the algorithm for your reference. This pathway will also be found in the documents page within Epic. So some specifics about the physical exam that you may wish to look for include nystagmus, test of skew, and the head impulse test, but only if you feel comfortable doing so and you've practiced. Only patients with nystagmus should you do the head impulse test on. It's very important to do a full and focused neurologic examination looking for subtle findings such as the cerebellar exam. You also want to be sure to test every patient for truncal ataxia, so ask them to sit up in the stretcher and see if they can sit up without holding on. And you want to be sure to also test gait. For more information and for specific videos about how to do each of these physical exam tests, scroll down in the associated educational website, and there are YouTube videos for all of them. For patients that you are considering BPPV as the etiology because they have triggered episodic vestibular syndrome, then you will do the Dix-Hallpike maneuver. Here is a screenshot that shows how to do this maneuver, but there's also a YouTube video on the educational website. This would be the diagnostic test for BPPV. To treat BPPV, you would do the Epley maneuver, which can be a continuation of the Dix-Hallpike test. Again, there's a YouTube video below for reference. So let's talk about testing. For patients that you are concerned have acute vestibular syndrome and you are worried about a posterior circulation stroke or TIA, you want to do imaging of the brain. This can be with a non-contrast CT head or an MRI brain. Some of the pros for the CT head is it's very fast and readily available. It will identify an intracranial hemorrhage fast. Or if you're worried about the patient that's had symptoms for some time and they might have some cerebral edema, this will also identify that. The cons are it's not great at looking at the cerebellum or brainstem. MRI brain is definitely a more sensitive test, but it is slow and resource intensive. There are also limitations if the patient has metal within their body. Something to think about if you're concerned about an acute stroke then we do have certain metrics that we need to adhere to. When a patient presents to the emergency room, they should have their imaging completed and read within 45 minutes based on CMS recommendations. So the CT head is a way to make sure that this is completed. Non-contrast head CT does have a pretty low sensitivity for all acute strokes, but even more so for strokes of the posterior fossa, which is around 41%. There was a large Canadian study of emergency department patients that were discharged with a diagnosis of benign dizziness. Those that returned back to the emergency department and were diagnosed with a stroke were actually 2 times more likely to have had a CT on the first visit. So the takeaway from this paper is physicians are correctly identifying which patients are worrisome for a posterior stroke, but they were doing the wrong diagnostic test and failing to follow up with the appropriate test in the patients with persistent symptoms. So MRI is one of the better tests that we have to look for posterior circulation strokes, but it's not perfect. Even up to 48 hours after symptom onset, you can have a false negative result in 12 to 18% of patients. So if a patient still has persistent dizziness or any neurologic findings, they should be kept in the hospital for further workup and repeat MRI after 48 hours if their symptoms persist at that time. For small strokes, defined as less than 1 centimeter, the MRI may even be falsely negative in up to about half of those patients. So just something to consider. So you've imaged the brain, and now you want to look at the blood vessels. So you have a couple of options. The fastest and most sensitive and specific test would be the CTA head and neck, which is 100% sensitive and about 95% specific. Alternatively, you can do an MRA head and neck, and this is without contrast, which has a sensitivity of 92% and a specificity of 76%. You are able to, if you're able to get the patient up to MRI and you want to do the MRI brain along with the MRA head and neck, it's just important to note that all of these tests are quite time intensive. So you are adding on probably another 45 minutes of the patient being on that MRI table, in addition to what they're already there for the MR brain. So the CT head and CTA head and neck can all be completed within 10 to 15 minutes, while the MR brain and MRA head and neck can take up to an hour and a half. If the patient has a contraindication to both the CTA and the MRA, then you could consider doing a carotid ultrasound, which is a little bit less sensitive and specific. So to put it all together, the reason for doing these tests is to also screen for potential underlying cause. So the patients that stay in the hospital, whether in observation or admitted to the hospital, whatever imaging wasn't complete in the emergency department, they will get it. And so if they had a CT head, then the MRI brain will generally be completed. If vascular imaging was not done in the emergency department, then it will be completed inpatient. You're going to keep them on telemetry to look for any paroxysmal arrhythmias. And for certain patients, you will look for cardioembolic causes. So as I said, the patients that stay in the hospital are placed on telemetry to look for transient arrhythmias. About 20 to 25% of all TIAs are caused by atrial fibrillation and atrial clots. About 2% of patients that are kept in the hospital with TIA have a new diagnosis of atrial fibrillation. Patients that have a normal screening EKG on presentation, no cardiac history or significant risk factors, and no clinically evident cardiac symptoms or exam findings like a murmur or signs of heart failure, less than 3% of these patients are going to have any significant abnormalities on echocardiogram. So you really want to be sure to think about what patients actually need it. So who does need an echocardiogram? As mentioned before, patients that have a new exam finding that might suggest they could have some sort of an underlying thrombus should have an echocardiogram. These are patients that might have severe CHF or an acute MI, atrial fibrillation, rheumatic heart disease, or other significant valvular disease. And some patients that just have a very classic story for a TIA that you're concerned could have a PFO. So these patients are ones that you might want to keep to do a TTE with bubble study. One other group of patients are those that are IV drug users that maybe have a fever or any other signs that could point you in the direction of endocarditis. So let's go back to those case examples I mentioned before. The first was the 65-year-old male with the hypertension, hyperlipidemia, diabetes, and stroke with residual left-sided weakness with 2 days of dizziness and lightheadedness, who hasn't taken his medications or ate or drank much because he's been so nauseous. You can see here that his vital signs are pretty unremarkable. So what will you ask? What will you look for on physical exam? What workup will you do? And what will your disposition be? Let's use the attest algorithm to go through this case. So when you ask about associated symptoms, he does say he's had difficulty walking during this 2-day time period, and he's been falling, and he feels like he's falling more often to one side. He's also had significant nausea and vomiting. So when asking about timing and triggers, his dizziness has been constant for the past 2 days, and it's still present right now. While he says it is worse when he's trying to sit or stand up, it is there all the time. And specific exam signs, you notice that he is past pointing on his finger to nose exam on his left side, and he also has an unsteady gait that appears to be a bit broad-based. So you decide to go to the T, which is the testing, and you order a non-contrast head CT. It doesn't show any acute infarct or head bleed or mass, but it does confirm his chronic infarcts. You decide to keep the patient in the hospital, and an MRI brain is completed, which confirms several recent infarcts of the medulla and left posterior cerebellum. So I use this case example because it is a case that was a delayed diagnosis of cerebellar stroke that prompted us to develop this acute onset dizziness pathway. This is a patient that had a prior history of a stroke with multiple risk factors. You want to be sure to do a directed neuro exam on all the patients that present with acute and persistent dizziness to avoid any delay in diagnosis and treatment of the posterior circulation stroke. And if a patient has persistent symptoms, be more keen to consider imaging and further neurologic workup. Now on to our second case. This is the 42-year-old male with hypertension that came in with dizziness that started when he rolled over in the morning. At rest, he's asymptomatic, but his symptoms do return when he turns his head. So again, the attest algorithm. Associated symptoms. He says he has been nauseous and he has vomited a few times. He's able to walk, but he does feel a little unsteady when he stands up initially, but that goes away within a few seconds. Timing and triggers. He does have dizziness, more so that's triggered when he turns his head to the left than the right. When he's resting, he doesn't have any dizziness. On exam, he has a positive Dix-Hallpike to the left, which means he has inducible nystagmus. He doesn't have any nystagmus at rest. He has a normal finger to nose exam, a normal cranial nerve exam, and his gait is normal. So this is a patient with a triggered episodic vertigo, so the triggered episodic vestibular syndrome. He was treated with the Epley maneuver and had resolution of his symptoms while in the emergency department. 80% of patients with BPPV that the Epley maneuver is performed on will have resolution of their symptoms. You can always repeat it if it doesn't work the first time. So let's run through the acute onset dizziness clinical pathway. The patient presents to the emergency department complaining of acute onset and persistent dizziness. In triage, the nurse will do the B fast and will ask about the timing. If it's been less than 24 hours and the B fast is positive, then a stroke code will be called. If the B fast is negative, then the patient will be roomed and the physical exam and history will be taken as usual. On your exam, if there's anything suggestive of central origin, then you will again ask the patient, how long have you had the symptoms? Has it been less than 24 hours? If so, they will be a stroke code. If it's been over 24 hours, then you will consult the stroke service and consider your imaging choice. We've included the CT head and CTA head and neck in the algorithm as it is the fastest way to get this imaging done and the fastest way to get you a diagnosis and not miss any acute strokes. If this imaging is negative and the patient has persistent symptoms or physical exam findings, then you might want to consider MRI brain and definitely consider keeping in the hospital. If the patient's initial imaging is negative and they have no findings on exam and their dizziness is resolved, in lower risk patients, you might consider discharging them. Other patients, you might consider keeping them in observation. Thank you. For further information, all of the references are listed at the bottom of this educational website. There are many YouTube videos here to help you go through the physical exam so that you can feel confident using them with your patients. And if any questions, please feel free to reach out to me at any time.